Hello and welcome. My name is Raj Persaud and I'm a psychiatrist based in London. And this is Headstarters, a series where I'm talking to young psychiatrists in training, about their experiences of embarking on this interesting, fascinating and slightly strange career of psychiatry, which is a branch of medicine. I'm joined today by Amanda, Dave and Niall. I'm going to start with you, Niall, because you have a very interesting story in that you actually were so put off doing psychiatry as a medical student that you spent many years wandering in the wilderness of general practice before coming back to psychiatry. And I'm starting with you because the topic that we're discussing this evening is what is it about the medical student experience of psychiatry that seems to put so many medical students off, or is it something... is there something that we can do to influence or affect the medical student experience? So tell us a bit about your experience, Niall.
Okay, thank you, Raj. I think that for me, and someone who went as a medical student was very keen on psychiatry, I think for starters, I suppose the quality of teaching that we got. I kind of went in with an open mind, and we would turn up in what I thought was a pretty dingy environment, where everyone looked pretty drab, and the wards were drab, and you just kind of walked around not quite knowing who you should attach yourself to or where to go or what to do, and there wasn't really any structure, and people weren't that enthusiastic about the subject, so it kind of seemed like it was just give people a lot of pills, and they'll either get better or not, and if they don't, they'll just be very chronically sick. And it just gave me a very, I guess as a medical student, there's lots of stuff that you don't understand about psychiatry, and you didn't really feel that you got any sense of what psychiatry was really about or the depth of it.
And so that put you off, and you went away and did other things. You did general.
I guess I did a liaison job, and that kept me and I started, in matter of fact, I started an SHO job in psychiatry, and I think that was probably the final nail in the coffin because I just felt again that it was a matter of coming in, giving people pills, not really having a great sense of a science behind what we were doing, and I thought there's got to be more than this. I was very disappointed and disillusioned by it, and I think possibly the people around me, the consultants and the other people that were there, needed to be a bit more enthusiastic. Everyone was, and I think that was what I expected. I expected to be led to people and to be told about various interesting cases, and it just didn't happen. So I embarked on a career in general practice for many years with a specialist interest in psychiatry, and that was a great kind of way to see psychiatry, but I wasn't quite getting the experience I wanted, so I changed direction again.
And you came back into psychiatry at some point, and you find it more interesting now. So
definitely, and I think as a medical student, I mean, I know now, I suppose, teaching medical students, I think that the key is, being older, you kind of got a more sense of what you want, and you can dig beyond things. But I think psychiatry's changed, and I think there's a lot of emphasis on good teaching and encouraging students and junior doctors as well. So I think it has changed, and I certainly try to kind of make my medical students interested in the subject.
So your take-home message might be, don't get put off if it doesn't seem right. If you keep searching, you may find the experience that draws you into what is a very fascinating subject.
Absolutely. I think that, if you're taken to a ward which is a chronic long stay ward, or there's an old age ward, there's another ward which is just not what you're into, ask around, ask someone. I think just go somewhere else, because there's not all bits of psychiatry suits every person. So I think there's a bit in psychiatry that you'll find interesting. Just go and search for it.
I think that's an important point. Well, when I did psychiatry as a medical student, I was attached to a very large old Victorian asylum in North London, which has subsequently closed and been converted into luxury flats, ironically enough. And when I first arrived there, it was a very disheartening experience. I was put off psychiatry completely. I then chose to do an elective in adolescent psychiatry at a hospital near St Albans as my elective, and it was very exciting and thrilling. There was something about adolescent psychiatry that was very fast-paced, and it drew me back into the field. Dave, you have an experience as a medical student which was actually quite frightening, and maybe that's one of the reasons that medical students get put off. Could you tell us a bit about your experience?
Yeah, by all means. I mean, first and foremost, what was rather amusing is sort of being met by this rather odd-looking man, very enthusiastic about psychiatry, but just seemed a bit weird, and he's just acting a bit weird, sort of inviting me into this ward again. I think there must have been the vogue around that time of having dark and dingy wards full of people not very much. But anyway, he brought me in and said, "I've got this really interesting patient for you," and proceeded to put me in a room with this patient, who later I found out was actually had been assaulting several members of staff due to his psychotic beliefs. And I did manage to elicit some of the psychotic symptoms, but little did I know that actually he like I said, he was dangerous. But I was left to fend for myself, and that was pretty much the start of my entire psychiatry placement, where I was just going from one thing to another off my own back, and there was very little in the way of structure or support. And yeah, I mean, that was rather off-putting when it came to sort of considering psychiatry as a career. And it's only later on that I, through foundation placements, that I actually decided, actually this is really quite interesting, and I'd love to go for this.
And what about you, Amanda? What about your experiences? Because in fact you had quite positive experiences.
Yeah, I had really positive experience of my psychiatry placement. It was in, I think it was a low secure unit, and so you might think that I might have had more experiences like Dave, where I was concerned about risk and that sort of thing. But it all seemed quite well managed, and I think possibly because it was a low secure unit, we were kind of taken to see patients and supported in that, and so the consultant made sure that we had access to actually really interesting people, and the way he taught us was really good as well. Like I think he was quite a kind of biologically minded psychiatrist, and that sort of appealed to me, and having done sort of the basic sciences and things, I'd just come out of the non-clinical years, it kind of fitted quite well, the teaching with the things that we knew already. So yeah, I did have quite a positive experience, but I have to say that I don't know that it is entirely down to the experience, because although my clinical partner and I had what I can only say is almost identical experiences. We saw exactly the same patients, we saw them together, we had exactly the same teaching. I really enjoyed it and really wanted to go into psychiatry as a result. And my clinical partner absolutely hated it and couldn't wait to never have to do psychiatry again. So I don't know if partly it's because I've gone into psychiatry and there's like an element of recall bias that I think, yeah, my medical student placement was fantastic, or if it was good and she didn't appreciate it, I don't know. But I think there's probably something about how well the individual suits the placement, as well as however good the teaching is.
You've also, I understand, had an experience whereby what you think is very important is the enthusiasm or the charisma of the consultant that you're attached to as a medical student. And I remember at medical school that the surgeons, the physicians, it was these flamboyant characters, maybe characters that wouldn't in a way be allowed to teach, be unleashed on medical students today, but these rather flamboyant characters that drew one in, that made you attracted to the subject. Is there something different, I want to put to you, Amanda, about maybe the experience of medical students being taught by consultant psychiatrists? Maybe they seem more exhausted or weary often by what they're doing, or maybe that's not fair.
Yeah, I guess it depends a lot on the individual, really, like who the consultant is, and because I think there are plenty of people like that in psychiatry, and I think medical students attached to those placements are really enthused by them, and a lot of people that I know can have someone in mind who has kind of inspired them in that career, But I think it's not just about some sort of innate trait of charisma. I think a lot of it is about enthusiasm and understanding a student's needs and providing encouragement to go into a career in psychiatry and supporting them in accessing the sort of teaching and learning opportunities as well. Like Dave and Niall both mentioned, a lot of their placements were very unstructured, and they were expected to just go onto a ward and seek out patients that, just at random, not necessarily that were particularly clinically useful or useful from an educational point of view to speak to. And I can see that you could feel quite lost, especially if you have perhaps slightly stigmatized ideas, which a lot of medical students and a lot of the population do, about people with mental health problems. So I think that perhaps my experience, because it was in the low secure unit, actually because it was so much more structured and the consultant had a real interest in us as students, I think that might have made a really big difference to the experience that I had.
So forensic psychiatry units, by their very, very definition, tend to be very structured places, and that may be a kind of good place for medical students to start. I want to go back to you, though, Niall, because your story is very interesting, because my sense about you is that you were kind of really wanting to do psychiatry from being quite a young doctor, and psychiatry was kind of keeping you at arm's length. Psychiatry was keeping you away. You actually got into psychiatry despite psychiatry, as it were. What are your thoughts?
No, I think that's very true, and my observations are, I guess, that I see psychiatry and general practice as there's a massive overlap with them, and I already see students who would be interested in psychiatry, but somehow in many ways it fails them, and so they take off to general practice. It's much more, I don't know, they know where they're going, they can see it's tangible, maybe it's the clinical aspect of it. I suppose for me, I was persistent, something I really, really wanted to do, but yet it took me a long time, and I was definitely put off. So I can remember even being asked to take on a much more involved role on the ward in psychiatry as a GP, and I just thought, no, I can't do this. And my lasting memories of the medical student days being on the wards and at that time, wards filled with cigarette smoke, and it was just dreary and drab. That's changed, thankfully, but I still think that now medical students, they turn up, and I think you've got to be really proactive to get them, as Amanda said, with a kind of biological slant towards psychiatry. These things are real. Psychiatry is not just by holding someone's hand and talking. There's stuff going on. And I can remember as a medical student, the one kind of lecture that stood out was about neuropsychiatry, and I remember thinking, that kind of hooked me.
But Dave, you have actually mentioned in the past that you thought, going back to sticking with the idea that the consultant psychiatrist you're attached to as a medical student is an important issue. You've commented, as I understand it, that you thought psychiatrists often look a bit strange, and that's part of the problem.
Not only do they look a bit strange, but act a bit strange as well. And to be perfectly blunt, I don't know whether I was just unlucky in the unit that I was placed in, but it was really quite off-putting, and everyone who was also placed there also had exactly the same sort of feelings about these group of weird people who just sort of congregated together, not doing very much with their patients who languished on the wards. Anyway, I mean, going back to Amanda and Niall's points, though, I totally agree that it's about introducing students to cases in a sort of structured and supported way to promote that learning. And I know that medical students miss out on a lot of the exciting psychiatry that happens around. You know, those people who are frankly manic or frankly psychotic and have some really interesting psychopathology that otherwise would just get missed if your consultant just says, go and see that chap over there who's been in remission, who's awaiting accommodation for the past 5 months, to talk to him about what happened, if he can remember. It is about that structure. Get people down to do and see those people that are exciting.
But also you commented, and it's a quite important point, that a lot of times when medical students arrive on the wards, not a lot seems to be happening. And people come into medicine because they want to do something. They tend to be action-oriented, and they're often quite impatient in the sense that they want to produce rapid change. So what about that point? I don't know, Dave, if you want to say anything about that. Puts a lot of people off. They don't seem to see that a lot is happening in psychiatry, which is not true. It just seems that way.
No, it's incredibly the other way. In fact, I guess I'm just fortunate where I work right now. It is quite action-packed. There's always something going off with one of the patients. And we're affiliated to quite a busy teaching hospital as well, so we do a lot of liaison work and work in A&E. So the med students get a real breadth of psychiatry experience, which we've received a lot of good feedback about. So in this current placement, I would like to say the med students actually get a very good experience. However, in some of the more district general hospitals, I know it can be a bit more sedate, so they do miss out on that excitement experience.
And Amanda, what are your thoughts?
Yeah, I think part of that is the way that the curriculum still puts psychiatry in a certain placement, and a medical student can be attached to an inpatient ward for a certain amount of time and have that experience. And really, I don't understand why we're still doing that. Psychiatry isn't just in inpatient wards. In fact, fewer and fewer people are even admitted. And so actually a medical student's experience, if they just are on an inpatient ward, is completely skewed towards an incredibly unwell subset of psychiatry patients. And I think actually if we were able to move the medical student experience to have a much better breadth, like it sounds like Dave's medical students are experiencing, by getting them into community clinics and having clinics set up so they are teaching clinics rather than just observing the consultants sort of doing their work, then I think that would add a lot more structure and give a much more realistic kind of overview of what psychiatry is about. And then you'll be seeing a lot of people coming back saying, you know, oh, that's really worked really well for me, and seeing much more positive elements.
Okay, well, we're running out of time a little bit, but one point I want to put to all of you is whether there's a sense in which my experience of one of the great satisfactions of being a psychiatrist is the intimacy of the consulting room, in the sense that people confide things that they often may not have confided to anyone else. But that's very difficult to capture teaching in terms of medical students turning up and partaking in the consultation. Sometimes you've got 4 or 5 medical students on the ward, or even if it's one other. There's a sense in which for the rest of medicine, demonstrating a medical sign or symptom is easier. They're more publicly observable. A lot of psychiatry doesn't seem to be easily publicly observable, perhaps. Let's go to you, Niall, in terms of what your reaction to that is, or whether you think there are other more important issues in terms of getting medical students into psychiatry.
I think you're right in a certain sense. So when we're there with the patient, it's very difficult to see, because as an experienced psychiatrist, the consultant knows what's going on and knows what they're saying, and sometimes that's not fed back. So it's much more difficult to use perhaps that patient, because of the nature of the illness, as a kind of teaching tool. So we can let everyone listen to the diastolic rumble of a murmur, but we can't kind of pick out and tease out the delusion or the hallucination whilst we're there. And I think perhaps when we're with that patient, very quickly afterwards, we need to go through that and make much more of the psychopathology, because that's the backbone. I think that's the exciting bit of psychiatry. Where has that come from? Where does that delusion come from, that hallucination? I mean, it's just, and of course, if it's just a massive rumbling and madness to the medical student, and it's not explained to you, you forget it and you switch off, and you're on to you're left to go to a very boring meeting, which you sit for 2 hours in. So,
yeah. Well, we'll have to reserve meetings for another podcast, because I do think that's a major thing that puts people off psychiatry, the number of meetings that psychiatrists seem to be expected to endure. But I want to pick up on that point. I think it's a really interesting one. I think one of the problems is you see a patient, they mention something, they say, I was in my room and I heard the neighbour shouting at me. Now, the psychiatrist thinks, aha, this is an auditory hallucination. He didn't really hear the neighbours shouting at him. That was just his rationalisation, his way of explaining the symptom. So you turn to the medical student when the patient's left the room and you say, well, what did you think about that? And you're trying to argue that you think that's an auditory hallucination, and the medical student will say, well, maybe the neighbours really were shouting at him. So the point is that symptoms are much more arguable over in psychiatry than they are in the rest of medicine. So it takes a long time to get the point over that sometimes a patient says something and actually the most likely thing is they're experiencing an auditory hallucination, but you've got to be experienced to pick that up, because it can be passed off as something else. I don't know, Dave, whether you feel that's an issue, that sometimes psychiatry, there's more argument over what's really going on, and that becomes difficult to teach then.
That's also part of the enticement of psychiatry as well, some of that grey area, and sort of piecing together what a person's story actually manifests itself, not only in terms of mental illness, but other sort of psychological issues and social issues as well. But picking up on the point about medical students sort of sat there and doing not very much and daydreaming about what they're going to do over the weekend, I mean, it is really quite important to sort of try to engage them actively in a process, even if it is actively listening. So setting up the medical students prior to that engagement is important. So to ask them a simple question: please observe what I'm doing in terms of trying to elicit psychotic symptoms. And then you can ask them, hopefully in a Socratic way, so what did you observe in that interaction? And then hopefully they'll piece together some sort of learning by that active listening.
Okay, well, thank you very much. And we've run out of time, so Amanda, Dave and Niall, thank you very much indeed for joining us for Headstarters, and we'll be recording another one soon. Thank you.
Thanks.
Thanks.
Thanks, Richard.
Thanks.